So thank you so much for being here. We have a very exciting program, and for session 1 today, our first speaker is Irene Zambelis. And she's going to be speaking to us about prescribed minimum benefits from basics to the latest. This is a very interesting topic for me, especially as an occupational therapist, because we seem to not be covered by almost anything with the PMPs. So it will be very interesting to hear what you have to say. So Irene has led the Institute of Health Risk Managers since its inception in July 2004. It's an independent training company with a specific focus on the healthcare industry. She has been facilitating, assessing, and moderating the Wealth Management Qualification Level 5, Medical Claims Assessing and Long-Term Risk Assessment Qualifications Level 4 since 2006, interacting with the financial planners, specializing for healthcare brokers, as well as medical scheme fund managers and trustees, medical scheme administration, and managed care staff. Irene is a qualified assessor and moderator. Her clinical experience as a nurse of many years and the related diplomas that she achieved, including teaching, equips her to understand health and illness and its related risks for providers and funders of healthcare. Her master's in business administration has equipped her to understand the fundamentals of business, finances, and the risks and risk management components essential for these qualifications. In addition, she has been actively involved in facilitating short courses on employee wellness, health legislation, health risk management, and case management. Thank you so much for being here, Irene.
Thank you, Tasneem, for those very kind words, and to Joey as well, and to all of you for this opportunity. As Tasneem said, we're going to be talking prescribed minimum benefits. And we all know, can you hear me? Is everything okay? We're a small enough group to keep it informal. I don't know for Tasneem and Joey, if you'll be happy with that you can put your hand up, ask questions. Joey's giving me the thumbs up. I mean, that's important that we can get that. So we're going to be going through what are the PMBs. I mean, Joey did ask that we cover the basics. What are they? What is the cost of prescribed minimum benefits? What is the scheme's liability in funding PMBs? And what are the proposed changes that are coming? We're hearing quite a bit of that. So the important thing, I thought, let's start off. We know medical schemes is funding. That's what it is. What do they pay for and what don't they pay for? So I thought just to give you a quick overview, how much money is collected in a year in medical scheme contributions in South Africa? These figures come from the Council for Medical Schemes annual report, and it's not a small number. 232 billion rand was collected in 2022 from South Africans into the medical scheme pot. Out of that, 232 billion in contributions, 224 billion actually went to benefits. So for me, the numbers need to be put into perspective. We need to ask ourselves a question. How well is this money spent? Are we getting good patient outcomes? And I think, oops, it seems like I'm going in the wrong direction here. Not such a good thing for a Thursday. So, before I get ahead of myself, what we've got to be able, oops, no, I am going in the wrong direction. Am I going back? The red one. Okay, thank you. I was pressing. I can't drive. I did drive here, though. So let's go there. I think that's where we need to be. So just to start it off when I was trying to get the pointer going, how many South Africans have medical scheme cover? And I don't know what your feeling would be. Think about how many you think. When we have a look, there are the red bar gives us the number of South Africans, about 62 million. We can, wow, I better, when we have a look, that 62 million, there are 62 million South Africans. The blue bar here says only 9.04 million of the 62 million have medical scheme cover. Now, if you think that they contributed the 9 million people, their contributions for a year are about 230 billion rand. The government pays for 50 million South Africans to run the public sector about 260 billion rand. So think of that inequity. How well is the money spent? So when we look at the green bar shows us what percentage of the South African population have medical scheme cover. And what we can see over time, from 2013 to 2022, the percentage of South Africans with medical scheme cover has declined. And that is a worrying thing. The other thing that I wanted to point out before we go into the PMBs, how financially sound are medical schemes? Let's not kid ourselves. They are financial instruments. They're there to fund healthcare services. So it's a financial product. How financially sound are they? Who agrees with me? Medical schemes are not for-profit business entities. Do you agree with me? Hands up. They are not for-profit. Does no one else agree with me? Have I not? They are. But how financially sound are they? An important thing, I don't know how many of you remember when Health Squared as a medical scheme went bankrupt. They stopped paying claims overnight virtually. Members were left with high-cost claims that they were still responsible for. So it's so important that medical schemes remain financially sound. What this graph here represents, the percentage of contributions spent on healthcare expenses. Now, we all know that that is the purpose of a medical scheme, pay the healthcare expenses. But we can see here, obviously, in 2020, this was the COVID honeymoon for schemes. Schemes performed very well financially in the COVID time. Not many people performed well, but schemes did. What we can see, post-COVID, the percentage spend has bounced back. So if you think in 2022, 93% of contributions were spent on healthcare. Now do the maths. On top of that 93%, you've got to add about 13% for non-healthcare expenses. I know it's early on a Thursday morning, but in my book, you've now spent more than the contributions you've collected. Which means schemes are eating into their reserves. How financially sustainable is that? Is the question we need to be asking ourselves. And what are schemes doing to change that trajectory? So, when did the PMBs come into place? In 2000 is when they came in. Schemes are compelled to fund in full the PMB conditions. There are 297 of them in total. Conditions, diagnoses. Now, I don't have to tell the audience how many conditions there are out there. Are there 8,000, 9,000 conditions that we can have? Only 297 are PMB. They divided between 3 groups. That's why I put the 3 lions. There are the bigger group, diagnosis and treatment pairs. The second group is any emergency condition. And the third group that you probably are most familiar with is the chronic disease list. This is written up in the Medical Schemes Act and its regulations. It's a good thing to be familiar with it, even though I don't think there are any lawyers in the group. Are there any lawyers in the group? One mustn't make an assumption. So why were the PMBs put into place? And I don't want to spend a lot of time discussing this, but I think if you read through the intention why PMBs were introduced is to say, let's have some equity. All medical scheme beneficiaries must have a minimum basket of benefits. Also, let's make sure that the private sector takes responsibility for paying the claims for their membership, and that we reduce dumping on the public sector that is already under-resourced. So that was the intention. They took the diagnosis and treatment pair package from Oregon in the States, and that was what was placed here. And they didn't, in fact, they took the conditions that Oregon put in place, but they didn't itemize the services for each of the conditions. Remember that, by the way, because that's the confusion today. What services are linked to each of those conditions? So the important thing that we've got to say, are the interests of medical scheme beneficiaries protected because of PMBs? And the answer to that, I think, is a unanimous no. It's a unanimous no from the regulator side, from providers side, from member side, the schemes, and that things need to change. We know that. Are any medical scheme options exempt from providing PMB benefits? Do you know of any medical scheme option that is exempt? No? You're right. No medical scheme option is exempt. However, those primary care policies are exempt by CMS, the Council for Medical Schemes. But no medical scheme got the exemption. In the Medical Schemes Act, the CMS has the power to grant exemption. So those primary care policies, by the way, the exemption runs out at the end of March. Alert. Will that exemption be extended? We don't know. And they're waiting to hear. And I mean, we're already virtually middle of March. So that is something that we need to understand. For providers, when you look at a patient with medical scheme membership, and you think, this is a PMB, my bill will be paid, is that not an important factor? Well, you may have a person with a PMB condition, and you know the services are PMB, but there may be a waiting period applied for new applicants. The way that the medical schemes apply waiting periods is very specific in the Act. So one needs to just be aware of that and look at the membership and understand PMBs may be excluded in certain situations. Can scheme exclusions apply to PMBs? You know, schemes can, in their rules, have certain conditions that they don't have any benefits for. The common one, which I think we all understand, is cosmetic surgery. However, PMBs cannot have exclusions. And that's important. But here comes the confusion. Schemes may limit the benefits to managed care programs. I really am. I'm going to blame what do I call this, the control. It's too sensitive, it's too good. So, managed care, and by the way, schemes spend about over 5 billion rand a year on managed care programs. Think of how much healthcare we could buy for 5 billion rand. If only the funders and the providers of healthcare could get together and agree that the patient is the most important thing here. And so we don't really need that managed care, but it's important. So, here comes the detail. By the way, we'll come a bit more to the role of protocols and formularies, because schemes have protocols in place, and they limit that PMB level of care to that. So, let's start off. If your patient has a PMB condition, this has got a life of its own. And you know it from the ICD-10 code. you've got to link the ICD-10 code with the severity of illness of the person. I promise I didn't touch it. To be able to come to the PMB treatment basket. So can we see, having a PMB condition doesn't mean everything will be paid. It's that PMB treatment basket. So for some of us, you may have a more severe form of high blood pressure. You'll be entitled to more benefits than someone that doesn't. I think the lion's really trying to make itself appear. So if we look at the lion's share, even that's disappeared, for PMBs. And this is the biggest group, the 271. You've got to look at both. You've got to look at the condition. You've got to look at the treatment basket. And then you'll know if it will be paid. The 271 conditions are divided into Annexure A of the regulations into the different body systems, which I'm sure I don't need to explain to you. How many of you are familiar with Annexure A of the regulations? So this is a cardiac condition, and we can see here it's myocarditis, transposition of the great vessels. So that is a PMB. But to understand what services are included, you've got to go to the protocol. They have added heart transplant. But I promise you, if you are 90, even though it's documented here, you won't qualify for funding for a heart transplant on the basis of not meeting the age criteria. So can we see it does become a bit more detailed. And that confusion is what we do believe is unnecessary. It's unnecessary. So if we now know we've got the right ICD-10 code, by the way, do you all work with that expanded ICD PMB coded list? If you need it, just tell Joey and we'll send it to you. And if you need a copy of the regulations, for those of you that may want to read the law, you are more than welcome to ask. Now, this is where the confusion comes in. The regulations say that for a PMB condition of the diagnosis and treatment pairs, what is PMB is whatever is best medical practice. So each scheme must go and put their own protocol together per condition. And tell me, how practical is that? We have 72 medical schemes in South Africa. And each medical scheme has a number of options with their own rules. So we haven't made it easy for ourselves. There's a lot of work we can be doing. But guys, just something that I think you must think of. Should your patient find that the protocol or formulary is ineffective, causes or would cause harm, you write a good medical motivation, and the scheme must fund the substitute in full. Medical motivation. To write it that our professor highly recommend won't wash it. You've got to be able to bring up the the facts. So let's quickly go through a scenario. You've got your patient. You're going to now say, is the ICD-10 code a PMB? If the answer is yes, you're going to say, does the claim meet the PMB level of care criteria? They're going to say, for your high blood pressure, 2 consultations. If this is consultation 3, you know you're in trouble for funding. Remember, schemes make funding decisions, not treating decisions. So then if you say, you've got to say, does my patient meet the criteria? Like high blood pressure, what is the blood pressure reading? And then, what is the defined basket? And what are the formularies and protocols? Are we comfortable with that? So, is there consensus in the room? Cancer's a PMB. Do you agree? No? Sorry? It depends. Aha. Isn't that a good word? Is cancer PMB? It depends. You're right, it depends. Because the law says it depends if it's treatable. So only treatable cancers are PMB. And it is. It actually tells you in the regulations what treatable is. So, I mean, you can argue it. Are we all happy? Let's go to the chronic disease list. I'm sure you've seen them. That chronic disease list is out. It's a smaller lion here, lioness, just purely because there are fewer conditions. The chronic disease list was published in 2004, 4 years after the diagnosis and treatment pairs. But for these 25 chronic conditions, they have published protocols, therapeutic algorithms for each of them. Unfortunately, those therapeutic algorithms have not been updated since 2004. We know there's been a bit of a time lapse. This is what it looks like, the therapeutic algorithms. They, in the public arena, you can get them. In this slide, I just want to bring up a point with you. Running your practice, keep your data. Upgrade your data if you haven't already done so. How many of your patients have what conditions? What are the health outcomes of those patients? And what is the cost of managing them? We are moving towards network providers, and you'll be positioning yourself in the driving seat with the data. So this tells us that from the Council's annual report, the highest cost driver for chronic conditions is high blood pressure. Isn't that surprising? Because it's actually a very low-cost condition to treat. But because so many South Africans have high blood pressure. So it's so important that one can see, and when you negotiate with schemes, you can say, look how well I treat. So the third group of PMBs is any emergency condition. It's the last lion of this pack. And what they've done is they have defined what is a PMB emergency condition. to something that is life-threatening, that requires immediate attention, going to an emergency unit of a hospital is not a P&B emergency. Because I could be having toothache at 2 in the morning and I can't sleep, so I drive to my nearest hospital. I mean, my jaw's not going to fall off because of the toothache. So it's important. The schemes will ask for detail. So, what should schemes pay for P&Bs? Joey, how am I doing for time? Tasneem? How much? 10 minutes. Okay. So, I know that you are interested in what should schemes be paying for P&Bs. So the law is explicit. Pay in full. However, let's have a look. What is the cost of P&Bs, the average cost of P&Bs to a scheme? And these are 2021 figures, because they didn't give us 2022 figures from CMS. The average cost of P&Bs is that blue line, 1,000 rand per person, guys, not per family, per month. So think of affordability of medical schemes. P&Bs are about half of the scheme's benefits. So how do you bring low-cost options together with this kind of cost? You can't. You can only provide a low-cost option if you do not provide for this P&B basket. What is also interesting in this slide is to look at the cost as we get older. So what you'll see on this slide is it's divided, I don't know, can you guys see, or am I in your way then? By age. So we all know preemie babies are expensive. You know what they say, the smaller the package, the higher the price tag. Unfortunately for neonates, that applies. So they come above the average. But then can you see the younger people come under the average? And when the rot sets in, I'm sorry to say, from 45, I won't say how long ago I saw 45. But can we see how the costs increase as the age increases? So schemes that have a lot of older people, all we can say is, oh, shame. So it's important. So the other thing that I found very interesting, that in 2021, the average number of admissions to hospital increased by 17.29%. We know it's the rebound effect that was happening. So your highest cost drivers, hospitals, specialists, medicines, then the Arama GP. But that can be a whole big topic. So what does the law say? The law says P&Bs must be paid in full. Invoice price, not the scheme tariff. As long as your claim falls within the P&B basket of services. It's not so simple. Remember, there's T's and C's. Without a co-payment to the member or the use of deductibles, and it's for the diagnosing the condition, investigations, etc., treatment and care. from the risk pool, not from the savings, as long as providers have allocated the correct ICD-10 code. Guys, I come from a training background. I don't have any foot in any specific camp. Trying to change an ICD-10 code so that a bill gets paid and not to please your patient, not because you are trying to be fraudulent, even though you are by changing that code, I must just add. It is though you've changed the data that the scheme collects and that you should have on your patients. So it is important to have the correct ICD-10 code. No PMB claim should be paid from a member's savings. We know that quite a few are, but they shouldn't be. In this slide, we're talking about schemes have the right to set up restricted choice of providers for their members, where they are saying to members, choose this group, this provider. The scheme must pay the bill in full if that service was obtained from a provider on the list. Should the member choose to use a different provider, a co-payment may be imposed. So I don't want to go to Tasneem, I want to go to Joe Schmo. That is my choice. But the scheme has said to me, if you go to Tasneem, no copay. So it's important that one understands that. But like life, nothing is straightforward. The regulations protect members when they don't use a service provider on their list. And it's something beyond their control that no copay must be applied. So can we see the devil sits in the detail, and it's important. So here comes managed care. We all know, for me, managed care is the way we should be going, that the right patient gets the right treatment at the right place at the right time, that the GP and primary care providers become the champions. I'm not saying it because it's a GP expert. It's important. Care coordination is important. The way schemes put their protocols in place, restricting services, they need to show the source of the protocol. So it can't be the scheme's cookbook. You need to say, I went to the Hypertension Society. Here's the protocol. And it is in the public domain, and the law says it must be based on evidence-based medicine, and that they must have protocols in place, looking at what is appropriate, what is clinically necessary, and how important it is. That's where your data is going to serve you well. The law also says, I don't know how many of you have asked the scheme for their protocol or their formularies, but they must provide it to anyone who requests it. Because if you look at this, scheme beneficiaries, I suppose that's providers, and any members of the public must be provided with the protocol. So I can't do a presentation like this and not mention outcomes measurements. Last week, we hosted an outcome measurement reporting conference, and how well do you manage the patients that you're looking after in health outcomes and cost? It's going to become more and more important. Just for completeness sake, there is a PMB Code of Conduct that was published by the Council for Medical Schemes. Schemes must be open and transparent about PMBs. It says how medical schemes should behave. If you want a copy of the Code of Conduct, please just ask Joey and I'll send you a pack with PMB stuff that you would like to use as reference. So here's the million-dollar question. What is going to happen to our PMBs? So the regulations say that PMB should be revised every 2 years. I say that it's the longest 2 years of my life because they came in 2000. And when I checked, we are in 2024, am I correct? So has any change taken place? No. Are they planning change? Yes. Are there initiatives in place to make changes? Yes. Please, though, in your questions, do not ask me when the change will take place. Because, like we say in this industry, you don't hold your breath unless blue is your color. We are waiting with anticipation for a change. There are many reasons why this PMB is not working. It's not working, it's made schemes too expensive, unaffordable. We're not catering to the low-income market. And people are not healthier because of it. So if we sort of look, what are the challenges that they have identified with the PMBs? There are many. And when I say the challenges, this isn't my view. This is industry view, CMS view. The health market inquiry, which was one of the best inquiries the private sector has ever had, says that the PMB needs to be reviewed. And this is where GPs need to come in. There should be compulsory care coordination in place. And that PMB should be risk adjusted. So if you've got more older people in your pool as a scheme, you won't be penalized because we know they'll cost you more. So, here are some dates. We're not going to go through them. We know the PMB review is ongoing. They have proposed initially with the PMB review that we move away from diagnosis-based PMBs to service-based. So in other words, instead of you covering the scheme covering my high blood pressure, they'll cover X number of consultations. And they put out a primary care package and a hospital package. However, don't think that is what is going to take place. Tasneem, this is my last slide. Is that on time? Okay. So we're sitting with a problem. Well, a few problems. However, we have a number of primary care packages that thousands, hundreds of thousands, and the numbers vary, 500,000 to 1 million people have these primary care packages. You need to know the difference when your patients come to you. What package do they have for funding? That primary care package carries very little, if any, hospital cover. So I can say to you, I've got cover, but it won't be much from that point of view. That ability for those products to continue may come to an end at the end of this month if the extension is not granted. So let's take a trip down memory lane. Where have we come from in catering to the low-income market? And where are we now? So the one thing is, and you can see I have gone back a bit, 2006, 2007, a low-income medical scheme was sanctioned by the Council for Medical Schemes. In 2015, there's a long lapse and silence. Doesn't mean nothing's happening at the council. Just means we're not seeing it. There were circulars on what the benefits could be. In 2017, they did publish the demarcation regulations, how health insurance is different to medical schemes. Keeping in mind health insurance is for profit, medical schemes not for profit. And then we got a surprise circular in 2019 from CMS. No low-cost benefit options will be allowed going forward. Sure. I think some of you will be able to relate to that. Then, in 2020, they established the low-cost benefit option advisory committee. And in 2022, the exemptions were rolled forward for the primary care options. And we are still waiting to hear for now what will happen going forward. Thank you for your time.